So we're going to continue on with our series where we have motion as a central component in our network of meaning, or in our semantic network. And we're talking about shoulder abduction. In this case, there is both glenohumeral abduction as well as scapular downward rotation. You could term it, but it's a joint set of movements between two connected but somewhat separate conceptually bones in the scapula and the humerus. So they're definitely connected, but there are ways in which you can cognitively separate them. But for the case here, we're looking at movement of the shoulder as a unit, or the shoulder girdle as a unit. So we'll talk about how this works with respect to both pieces independently, but also as a unit. Now that said, as we are continuously doing when speaking about the motions within the shoulder region, we're talking about it in a fairly broad way, because if you look at the neurovascular bundle, whichever movement ends up being the problem, you still want to check all of the other areas with respect to the shoulder, because the neurovascular bundle, you don't have to be particularly specific about it because of the places that it passes. And if you find the movement that's the problem and you behave according to the movement problem, you usually end up appropriately interfacing with any mechanical interference with the neurovascular bundle. So we're still going to be very general, and we're still going to say almost the exact same things as we've said in other videos about the shoulder region, because you want to check the medial border of the scapula, the lateral border, the anterior region, essentially the pectoral region. You want to check the neck, you want to check the T-spine, you want to check the ribs. You want to check all of these things on account of the fact that even if there's a primary movement that's the problem, the other pieces may also have some stuff going on, and you want to check it all. Now you could make the argument that that could be said for many places, but the manner in which you will eventually end up developing an assessment protocol where you will check everything in the body in a very large way, very quickly, you'll identify the areas that require more assessment or more investigation very quickly, and then you can be a little bit more specific. But generally speaking, you check everything and then you work on what's the problem. The same would be said of any area, and obviously we've repetitively said that about the shoulder. So our main objectives is to have a specific discussion of what shoulder abduction is, such as in the form of the planes and axes, a very general discussion of the muscles that abduct the shoulder, a very general discussion of the nerves that supply those muscles, a very general discussion of the vascular supply, a general discussion of the areas to assess and treat should shoulder abduction issues be suspected or reported. So we do our quick overview of planes. The sagittal plane is a 50% cut of the body left to right. Horizontal plane is a 50% cut of the body top to bottom. Horizontal or transverse. Frontal plane or coronal plane is a 50% cut of the body back to front. Now, in a relative sense, abduction is movement away from the midline. Right now, you can make the argument that eventually, once you pass 90 degrees here or parallel with the floor, now this is coming back towards the midline. But it's movement away from the midline of the body from the anatomical position. The anatomical position being, at least with respect to the arms at the side and palms facing forwards. So this is shoulder abduction in a very general sense. So it's occurring in the coronal plane or in the frontal plane, and you would consider that it would be, again, about an anterior, posterior, anterior axis. However, the only place that you would find something that looks a little bit like that in a true sense would be the SC joint. So where the sternum and the clavicle meet, or the clavicle and the manubrium and sternum, depending on how it's set up or which resource you read. But basically the sternoclavicular joint is the place where you'd have something that would look a little bit like an axis for this. In the case of the glenohumeral joint, it's multiplanar and multiaxial, so you don't necessarily see an axis, such that the hypothetical axis, or the predicted axis, would be determined by the muscular pull. And the same would be said with respect to the movement of the scapula, because you get a rotation, I believe it's appropriately termed downward rotation of the scapula, in concert between the trapezius, or the lower and middle fibers of the trapezius, and the serratus anterior. There is no true axis as far as, say, a point that's pinned, but the combined action of the muscle creates it. So if you're going to talk about it, abduction is in the coronal plane. There is no true axis that you could pinpoint, but the predicted axis would be in multiple places as determined by muscular pull. So the muscles that are going to do this, they're not absolutely all visible within this picture, but this picture just kind of gives a general idea of the area. The supraspinatus, so essentially the suprascapular fossa, So above the spine of the scapula, going to the humerus, you have the supraspinatus. Now, the supraspinatus is technically responsible for the first 15 degrees. So if the scapula is still and you need to pull on the humerus, the supraspinatus would technically do that. Usually there's going to be some other co-contraction and some other movement when you're actually looking at this in a living person. But for argument's sake, the first 15 degrees is the supraspinatus. The next 15 degrees is, if memory serves me, primarily the middle fibers of the deltoid. Subsequent to that, the next motion is the trapezius and the serratus anterior. Now, the serratus anterior, the reason it does it is because essentially what ends up happening is it fixes against its rib attachments, its anterior, lateral, or mid-axillary rib attachments, and then it pulls on its other attachment, which is the anterior medial surface of the scapula. So it's going to pull it essentially sort of around the front and tip it down towards the anterior attachments. And then the trapezius will do a similar thing, especially with the middle and lower fibers. As far as nerves are concerned, so we're just going to touch on this really quickly. The supraspinatus is the suprascapular nerve. The trapezius is the accessory nerve, so it's a cranial nerve. The deltoid is the axillary nerve, and the serratus anterior is the long thoracic nerve. Now, all that said, you don't have to pick those apart. You deal with the movement, because chasing those little nerve fibers, you won't find them. They're going to be slightly different in each person as far as exactly where they're laid out. You won't be able to palpate them. So you deal with the movement. And if the movement is the thing that is causing some interference with those on a mechanical level, then changing the movement would predictably change that mechanical interference. But just very superficially, you've got the supraspinatus, the middle fibers of the deltoid, the serratus anterior, and the trapezius. Just wanted to make sure I said all those. As far as the neurovascular bundle, this becomes a very similar discussion in everything that we're looking at with respect to the shoulder, because although it's in fairly confined spaces, it is in a lot of spaces. So you'd have to look at a very large area in order to deal with the neurovascular bundle. If you're thinking about circulation, you're thinking about the subclavian circulation, you're thinking about the carotid circulation, broadly speaking, you're thinking about the axillary circulation as well. You're not necessarily getting into brachial circulation yet, but you're thinking about axillary circulation. So you're essentially in a position where you have to attempt to identify movement issues with respect to the cervical column, with the clavicle itself, with the axilla. So you're thinking about pectoral tissues, you're thinking about how the scapula is relating to that, because that is going to form the axilla. So the posterior border is off of the scapula. So you're thinking about a lot of these things such that if all movements are okay, aside from one movement, in this case, shoulder abduction, you deal with shoulder abduction. If there is a neurovascular problem related to the mechanical interference, that should predictably help it. So you don't have to think necessarily in a specific way about the particular nerve fiber. You need to think about the motion, because you will be quite accurate to the problem at hand when you identify the motion problem or motion problems. Which brings us to our areas of consideration for assessment and treatment. This is consistent with all of the other shoulder discussions or scapular discussions we've had so far. You're thinking about the clavicle because of the neurovascular bundle, be it the subclavian vasculature, as far as the lymphatic circulation, so the right lymphatic duct and the thoracic duct, going into the subclavian vein on either side, the subclavian artery, the axillary artery, the carotid circulation. You're thinking about those things. You're thinking about the passage of the brachial plexus posterior to the clavicle in through the axilla. You're thinking about the cervical column because of the scalenes and their possible impact mechanically on subclavian circulation, on the brachial plexus itself. You're thinking about muscular connection. So you may be thinking about the levator scapula for some reason. You may be thinking about the trapezius here. You're thinking about the thoracic column generally. So things such as the rhomboids, things such as the trapezius, all borders of the scapula. So the medial border, the lateral border, and then the pectoral muscles, which would essentially be the anterior border because of the attachment, not only to the clavicle, but also to the coracoid process in the pectoralis minor. You're thinking about the ribs as well. So these are all consistent areas to check, regardless of the particular shoulder motion that you find, which is a problem, on account of the fact that although you may have a major motion problem, a major identifiable motion problem, you still want to consider the other ones because they may contribute to it. So shoulder abduction can be more or less pure in the coronal plane because of the way that the muscles will generate it. Or what you could notice is that when shoulder abduction, even though it's restricted, so it may not come up on the camera here, but you can see my arm going back and forth, right? So let's just say in that relatively pure coronal position, abduction looks like this, it's incomplete. Well, it could also look like this, so the arm could be forwards, right? So while shoulder abduction may be the major problem, the fact that I can't get back towards the pure coronal plane, there may be some issues with the pectoral tissue. So you still want to check the entire shoulder girdle in a fairly organized fashion, because although you may have a major motion problem, you may also have a minor motion problem or something that's smaller than the shoulder abduction problem that you may or may not find. So you still check it all. And then you behave again according to the motion problem or motion problems that you identify, because if there is a challenge with respect to mechanical interference with the neurovascular bundle, dealing with the motion should predictably have a positive impact on it. Now, this is a consistent statement in almost all areas, with some slightly more particular, but with respect to red flags and contraindications, known fractures or tears, do not treat, especially in that region. You may be able to do something positive for the patient as an overall entity, but you will not necessarily, you will not treat in the area of a known fracture or known tear. You also won't do anything that could generate pressure or tug on those areas. Suspected fractures or tears, refer out. If there is no evidence upon referral of a fracture or tear, you can consider it somewhat clear, but you still proceed with caution. Recent dramatic changes in cognitive functions, so you don't have to pick apart what these could be, but changes in speech, changes in memory, changes in the ability to identify things, anything cognitive is an immediate referral. That's an immediate red flag. You don't have to pick apart what it is. You just have to know that if there's recent dramatic changes in cognitive function, you don't treat, you refer out, there's major danger. Recent dramatic changes in respiration could be a pneumothorax, could be an underlying lung pathology that you're unclear about, could be a heart problem that you don't know about, or that the patient doesn't know about necessarily. This would present as recent changes in the ability to, say, get up a flight of stairs without being very breathless. Anything recent and dramatic with respect to respiration is an immediate referral out. You don't have to pick apart what it is. You just have to know that that is an immediate referral because there's danger.